Everyone, welcome. Let me share my screen. I believe I also shared my personal notes. Pardon me, I am definitely a teacher, and I don't like when everything I say is written on a PowerPoint. So I provided my talking notes for you as well. Let me get going. All right, can everyone see my screen? Adrian, thumbs up. Okay, cool. All right, so I am a big nerd, just so you know. And I love talking about genetics. And I want to make sure that when we go through these slides, if you have any questions, by all means, put them in the Q&A box. We'll get to the questions at the end. I'm not going to disrupt the flow in the beginning, but feel free to ask anything and everything you can possibly think of about genetics. I'm going to try to make it as informative and useful. So if you're already doing genetic testing, you can go in next week and start implementing some of the things I say. If you haven't taken a deep dive into genetics, I'm happy to talk about it even more with you. I love answering questions about a variety of genes and types of testing and what's useful for you as a healthcare practitioner. But today, what we're going to do is talk about what I lovingly call my top 40 countdown. So I am a child of the 80s and 90s. So if you remember Casey Kasem, that's what we're going to do, but in the genetic world. So top 40 countdown are literally the 40 genes that I personally use in my own practice and think that if you're a nutrition-based practitioner, they would be extremely useful for you to use as well. So as we go through this, I'm going to take apart different aspects of the genes I have listed and how they might relate to you in practice. Okay, here we go. Now, throughout this presentation, what you can expect. We're going to talk about genes related to gluten and dairy sensitivity. That's a big topic for most nutrition providers. We're going to talk about metabolism, how you deal with your fats and your carbs specifically. So if you run a weight loss oriented clinic or a weight management oriented clinic, those can be very useful. How you metabolize vitamins and minerals. This is a big one for most nutrition practitioners. The genes related to inflammation, detoxification, and my personal favorite, neurotransmitters. So that's going to be the flow of this presentation. So make sure you put those questions in the Q&A for me. All right. Before we get into the nitty gritty of genes, I want to talk about what this is and what this is not when I'm talking about genetic testing. First of all, what do we mean when we say genetic testing? Because that can be anything from paternity tests to ancestry, which is what most people think of, quite frankly. And we can even talk about pharmaceuticals. When I'm talking about genetic testing, I'm specifically talking about nutrigenomics or nutrition-based genetics. I'm not going to tell you you have a 0.1% from Sweden or whatever your ancestry might be. I'm not going to tell you who the baby daddy is. I can't tell you based on our tests alone. And I'm also not going to dive into the world of medical genetics, which requires a specific degree. So medical genetics are, do you have a disease-oriented mutation in your chromosomes? We're specifically going to talk about nutrigenetics, or how your genes affect the way you metabolize nutrition and how your nutrition affects the way your genes function. Goes both ways. So we're specifically, when we're doing a nutrigenetic test, we're looking at genes that influence your diet and lifestyle, to put it simply. I'm not going to be telling you anything else. And one of the things I really want to emphasize is when you are looking at a genetic test based on a nutrition lens, we're not looking at disease processes specifically. We're also not looking at pharmacogenetics, which is how you utilize medications. There is some overlap in both of those, but we need to be very cautious when we're talking about that. I'm a DC, I'm a chiropractor. It's not in my scope of practice to talk to you about medication. It is in my scope of practice to talk to you about nutrition. And I think genetic testing is, in the nutrigenomic sense, is better utilized in the nutrition world versus just the medication or the medical diagnosis world. That's a completely different beast. So I want to make sure that's clear. Next is, let's get some vocabulary or jargon down, because I see a lot of misuse with specific words. So really quick, how many of you have ever heard of homozygous or heterozygous homozygous. In the genetic world, there seems to be this hierarchy of terms that people think it means good, bad, and ugly. And I want to get us away from that. For example, if I have a gene that, and we'll talk about it in a minute, called MTHFR, which is the one gene that everyone seems to have heard of, and someone says, "Oh, I have a homozygous mutation of MTHFR." They've just told me number one, mutation, which is not a word you're ever going to hear me use, and I'll get to that in a second. Number two, they said homozygous, and they said it in a way that makes it bad. Homozygous simply means you have two variant copies of an allele. Okay. I just said a lot of big words that some of you may not understand, and that's fine. So let's make sure everything's really clear. When we're talking genetics, and this is in my notes, so feel free to look at that later, especially if it doesn't make sense with me just going blah, blah, blah. When we're talking genetics, we are specifically talking about allele pairings. So mom gave us an allele and dad gave us an allele. That makes our allele pairing. Now, the alleles in genetics are specifically what determine how that gene functions. So, for example, if I have one common or wild type allele from mom and one common or wild type allele from dad, theoretically, that gene is going to function how we expect it to function. Fair? If mom gives me a variant copy, a different, not common allele, and dad gives me the common one, wild type, it may alter the function of that gene. And if mom and dad give me a variant allele, a changed allele, it's definitely going to alter the function of that gene. Hope that makes a little bit of sense. I don't really have a visual way of showing that. But when we're talking genetic testing, it's very important that we understand that alleles change, and whether it's two variant copies is homozygous or one is heterozygous, none is wild type, that doesn't mean it's good, bad, and ugly. Wild type isn't always good. Homozygous isn't always bad. It just means it's different. Fair enough? So if I say those words, I'm literally saying the change in this allele is either heterozygous or homozygous, one from a parent or two from a parent. Hope that makes sense. Next, testing methods. For me, I use a simple cheek swab. You can get DNA from blood, hair, cheek swab, saliva. There's a variety of ways of doing that. I like the cheek swab because it's non-invasive, super simple. We send you a kit to your house. You send it back to our lab. Very easy. But we're also specifically using the gold standard testing methods using mass spectrometry and really setting our specificity and sensitivity very high so that the computer can pick up any changes or variations within the genome. Cost for us, when we're doing, let's say, 40 genetics on a panel, it's fairly affordable. It's around 175 or something like that. When you're looking at whole genome panels, which you're looking at the entire genome, specifically for mutations, it doesn't even really work in the nutrigenetic world. You're talking thousands upon thousands of dollars, which is what most people are thinking of when they're doing medical genetics and stuff like that. And then how does it fit into practice? I want to get into the genes so you can really see. But for me, if you do genetics at the beginning of a nutrition patient, you're going to take a lot of guesswork out. You're going to be able to say, okay, I see, Sally, that you are really bad at metabolizing carbohydrates. Carbohydrates may play a role in your weight gain, dental caries. It's something that causes inflammation for you. So we're going to reduce the carbohydrate and put down a low carbohydrate diet. Wouldn't you like to know that in the beginning? Or if you're heavy on the supplements like I am, if I need to know this person can't metabolize beta carotene, I can put them on retinol palmitate for vitamin A and bypass the gene altogether. So for me personally, I believe it fits into any nutrition-based practice by taking the guesswork out right at the beginning and cutting through all the trial and error that you often have to do in that kind of practice. All right. So let's dive right into these genes. There's 40 of them, like I said. And it's going to sound like I am the teacher from Charlie Brown, just want, saying, lots of Scrabble words, throwing out letters at you, numbers at you, and that's okay if you're like, what did she say? How many letters was that?" It's really okay if you don't get it the first time around. That's why I have it all written down for you. But these genes are really interesting from a nutrition perspective, at least in my opinion. So the first set of genes we're going to talk about are food sensitivity genes. The two main categories I really like to prioritize are dairy and gluten. So dairy, starting off strong, MCM6. This literally determines whether you're lactose intolerant or not. And the vast majority of people are lactose intolerant. So you could say, then why do we need to test that gene? I use it because so many patients just don't want to do what I say. And most people are like, I know I'm lactose intolerant. You don't even have to test my genes for that. Sure. But if I put it on black and white paper and you know your gene, you have a gene that says you can't digest lactose, chances are you're going to actually follow my directives versus not. So that's why I put MCM6 there. Now, the fun thing here, this is the perfect example. MCM6, the wild type allele pairing, so the most commonly found in nature pairing, is actually lactose intolerant. The heterozygous and homozygous pairings, the ones that have changed over time, are the ones that say you're lactose persistent or lactose tolerant. So this is a great example of why wild type, or the most commonly found gene pairing in nature, isn't necessarily good. It's actually the variation or the variant copies that give us a little bit of leg up. And you can look into the evolution of MCM6. It's quite fascinating, from people being famines, basically creating the variant copies, and people now have to survive on dairy. So that's the fun thing about that one. APOE, this is a very important gene if you're running any sort of weight loss oriented programs, because this gene says if you consume full fat dairy, you're going to gain weight. So it's highly linked to obesity. It's mostly due to an inflammatory cascade, but full fat dairy will cause weight gain and inflammation in people who carry the variant copy of this gene. So I love using this, especially for my vanity patients, which we all have, that say, I'm never going to give up dairy. Why would I do that? And I can look at them and say, okay, that full fat cheese you're consuming, the cheddar, is keeping the weight on you. So if you really want to fit in your bridesmaid's dress, maybe you should give up dairy for a while. And sure enough, I always use it in a short term, because they see within weeks, like, oh, I lost 5 pounds because I haven't had cheese. And then they choose to either stay with it or not, but they can at least see the effort of eating for their genetics. Next is gluten. This is a very important one, because in this, we're not just talking about celiac oriented genes. We have non-celiac gluten sensitivity genes as well. So if you take care of a lot of autoimmune patients, this is where these genes become important. We do have the two main celiac genes. I would argue there's multiple celiac genes, but the two that have the most amount of research are HLA-DQ8 and 2.5. If you have one variation of these genes, you're going to go anywhere from a 10% to a 75% potential of developing celiac disease. So if any of my patients come in with digestive, neurological, or skin-oriented symptoms, and they have at least one variant copy of these genes, I'm putting them on a gluten-free diet for sure. For example, even if they have, I think it's HLA-DQ 2.5. Forgive me if I'm wrong on my numbers, but I think if you have one variant copy there, you're 10% likely to develop celiac disease if you consume gluten. So I use that one a lot to be like, maybe you should be gluten-free, but if they have symptoms of any kind, absolutely. And guess what? No one's coming to me for wellness care. So most of them go gluten-free. MYO9B is my second favorite gene, however. This gene says, if you consume gluten, you are more likely to develop an autoimmune disease. And by that, we mean anything from rheumatoid arthritis to lupus to Hashimoto's. It doesn't have to be celiac. So this is your non-celiac gluten sensitivity gene. If someone is dealing with autoimmunity and they have a variation of this gene, automatic gluten-free for life. It's the fastest way I've seen autoimmunity go into remission. And it's also the fastest thing I've seen come out of remission. So people get a little complacent when they go gluten free, they're feeling good. They're like, I can just have a little bit of sourdough bread. And then it's low gluten, right? And then here come those autoimmune symptoms when gluten is involved. Okay. So that's a really important one if you take care of autoimmune patients. TNF. This is related to TNF alpha, the inflammatory cascade. This also says that gluten causes inflammation, and it may be generalized systemic inflammation, or it could be autoimmune oriented inflammation as well. Okay. Now, those are my biggest gluten oriented genes. Are they the only ones? Absolutely not. But they're the ones with the most research behind them, and they're the ones I find most clinically relevant. Next, metabolism. By this, we mean how do you metabolize your fats and your carbohydrates, especially in a world where everyone wants to do a named diet, keto, paleo, Mediterranean, whatever it might be. How you metabolize your fats and your carbohydrates is extremely important. Now, I used to just use these based on my weight loss clients, but I find that it's good for my cardiovascular clients, my autoimmune patients, no matter, it's really great for everyone. So the first one is the main fat metabolism gene. Now, let me just do a bit of a caveat here. Almost everyone is sensitive to saturated fats. So I don't use a gene specific. I used to, but I don't use a gene specific anymore for are you going to be sensitive to saturated fats? Because it always came back as yes, you're sensitive to saturated fats. ADIPOQ specifically says, are you sensitive to fats in general? So we can talk about any fat in this. It's not just saturated. So it is rare that people are sensitive to unsaturated fats. So for people, I used to call this my keto diet gene. If you were sensitive to fats, you couldn't do keto. But in reality, you could be doing a Mediterranean diet. And if you have this particular variation and you're sensitive to olive oil, it's going to be a problem. So this tells us, are you sensitive to fats? Is it going to specifically cause inflammation? The next ones are really fun, and I think probably even more applicable in a clinical setting. PLIN is, I like to call it my diet gene. So if you want to prescribe a specific named diet for someone, this is a great one. So this determines if a low carb or high carb diet will help with weight loss. And what we really mean by carb here, carbohydrates, is do you need excessive fibers? Do you need less fibers than the average person? Can you handle sugars? What is it? So if it comes back and says a low carb diet would help with weight loss, like maybe you should follow paleo, something like that, then what I'm really saying is let's remove the grains. We're automatically going to be removing the bad things, right? The white sugars, the pastries, the cookies, the cakes, all that jazz. But should we remove grains or not? Should we reduce legumes or not? For someone that says a low carb diet would help with weight loss, we pretty much go a paleo style diet. Lean meats, if they are a meat eater, fruits and veggies all day long. I never, ever take away fruits and vegetables of any kind. Okay. If it comes back as a high carb diet, these are my people that I typically put on a Mediterranean style diet. They can do whole grains all day long and lose weight. They can do legumes. They can do fresh veggies and fruits. They can do lean meats. Fiber is their friend. And that is the key takeaway for the carbohydrate metabolism. Can you really control fiber or not? The fiber is going to help with weight loss in the high carb diet people. So that's how I use it. FTO specifically is named the obesity gene. Unfortunately, this is one that I have had and deal with my entire life. And this is actually one of the things that got me into using genetics for my clinical practice. Every person with FTO is going to struggle with weight, period. I have not met anyone who is underweight with an FTO variation. So FTO is that thing. I don't want to say it is incredibly useful, but it is incredibly empowering. So if a person understands that they're going to have a bigger body than the average bear, they usually don't get so down on themselves for being overweight if they are. So when they have the obesity gene, it's okay, I'm going to be a bigger framed woman, period, my entire life. But I know that I can use these other things like how I metabolize carbs or fats or vitamins to make myself healthy. And then it empowers the person to really figure out what's going to work for them, where they're comfortable, and really love their body no matter what. So I use this gene for that purpose. AMY1, however, I think is extremely useful because this determines your need for digestive enzymes. Specifically, this gene says you can or cannot create enough amylase in your saliva to start to digest carbohydrates. So if you are a high carb diet person that has the obesity gene and you have a variation in AMY1 that says you don't create digestive enzymes, if you eat carbohydrates of any kind, even fruit, it may be hard for you to digest those sugars and it may increase pounds. Okay. So AMY1 is helpful for knowing if you're going to put someone on if let's say they have gastrointestinal issues or you're a weight management patient, knowing that if you put them on a digestive enzyme specifically that has amylase in it, they're going to better absorb their carbohydrates and utilize them. And maybe you can reduce things like insulin resistance and diabetes. So it's really important. Side note for any of you that might be in the dental world, AMY1 also says if you have this particular variation, you're going to be more prone to cavities. So for kids that seem to get cavity after cavity and their parents say they don't eat any sugar, it's because they have an AMY1 gene and they actually need digestive enzymes so they stop getting cavities. I know I'm going really fast, so be sure to put those questions in the chat box. I'm hoping that you get a lot of individual nuggets out of this. So this is where it starts to sound like Scrabble. Okay. Let's talk about the genes that control how you metabolize vitamins. That's a lot on one of these slides, and that's just part of it. Okay. So vitamins, and then we'll get into minerals. Most people that are coming to a nutrition-based practitioner, or I should say most practitioners that prescribe supplements, aren't always informed about the nature of bioidentical or bio-individualized or better absorbed, I should say, vitamins. And the reason that we usually in the functional medicine world talk about better absorbed or bioavailable nutrients is because of these genes we're about to talk about. Okay. Variations of certain genes literally determine your potential for deficiencies. Now, I love running micronutrient tests on my patients along with genetic testing. So if I know that they're going to have specific variations of certain genes, I'm expecting to see a deficiency on a micronutrient test. And almost always, if they're a high potential for having a deficiency, I almost always see that deficiency unless they're supplementing already. So let's run through these and talk about why they're important. The first one, CYP4F3, is all about how you metabolize vitamin K. This is going to be your person that has a high need of taking K2 with their D3. Specifically, it says, and this is, let me do a generalized statement for all of these vitamin and mineral oriented genes. These all determine how well you metabolize your dietary forms. So if I eat a bunch of citrus fruits, I'm expecting to get a bunch of vitamin C. But if I have issues with these genes, I can eat citrus fruit all day long and I still may be vitamin C deficient because I'm not metabolizing the vitamin or mineral from the dietary form into the cellular or bioavailable form. Hope that makes sense. Vitamin K says you can not convert K1 into K2 very easily. Now, this is usually a bacterial requirement. If you have the right gut biosis or biome, you have the right bacteria in your intestines, you're going to be able to convert vitamin K1 into K2 pretty easily. But if you have a genetic variation and you have gut dysbiosis, which so many people do, then you're not going to be getting enough K2 in your diet. So supplementation of K2 along with D3 generally is typically recommended. I will say this is not something I see that often, but it is something to consider. I'll also say, I'll also say that when you have this, it may be more important to use all your fat soluble vitamins together in supplement form versus just K by itself. Excuse me one second. All right. Sorry about that. All right. Next, we have two genes for vitamin C, SLC23A2 and SLC23A1. Vitamin C is a fun vitamin because we do not inherently make it. You have to get it from your food. But if you have variations of either of these genes, then you are going to be less able to metabolize your citrus fruits, the vitamin C from your citrus fruits or your bell peppers or your broccoli, and in order to get enough vitamin C. So supplementation may have to occur. I see this a lot on organic acid tests. So if you utilize those in your practice and vitamin C is low, oftentimes they have a variation of this gene. We have to be slightly cautious because obviously vitamin C can cause some gastrointestinal distress if utilized too much, but it is something to consider. And I will also say people that have this particular gene, I see a lot of skin issues. I see a lot of varicose veins, cardiovascular type of issues, and high blood pressure. Those are probably the three things I see most often when this gene is involved. And again, usually it shows up on an organic acid test as being deficient. Intergenic. Intergenic is vitamin E. I see raised hands real quick. I'm going to get to all your questions at the end. So if you will put them in the chat box or the Q&A box, we will definitely have time for questions. So intergenic is the vitamin E oriented gene. So if you can't metabolize enough vitamin E from your diet, you're prone to deficiencies with this genetic variation. I see this a lot with psoriasis and eczema. My pediatric clientele, which I take care of a lot of animals in my own practice, but my humans are usually the autoimmune moms and spectrum kids. That's my people. Vitamin E is very prevalent in anyone with a skin issue. So if I see eczema in a baby, vitamin E, absolutely. If I see psoriasis, vitamin E. And sometimes I don't always have to give them oral supplementation. I might use a topical cream or oil, and it works beautifully. But vitamin E is almost always deficient in those patients. GC is one of the most well-researched genes for vitamin D deficiency, specifically vitamin D deficiency that responds to supplementation. There's a lot of vitamin D-oriented genes that we could talk about, the VDRs. There's all sorts of them. But I find that GC is the most prevalent, so you're going to see it a lot more often. And it does respond if they have the genetic variation and they have a vitamin D deficiency, they typically respond well to supplementation, even on just a basic daily dose. So that's something to consider. Basically, this gene says you're not really going to metabolize vitamin D from your food or sunlight. So that's something to consider. NBPF3 is another one that is actually a problem for the wild type. I think vitamin E1 is too, but don't quote me on that. But you're going to see a lot of people with the potential for vitamin B6 deficiency if you run genetic testing. And I think that is an obvious vitamin deficiency, especially in mental health, because B6 is needed for methylation. It's needed for so many other processes in the body. And because most people are prone to deficiencies, it would make sense that they are deficient. And therefore, we're seeing a lot more mental health concerns, especially when it comes to neurotransmitter metabolism, which we'll talk about in a second. Hopefully, I'm not going too fast for you, but let's get into the really fun ones that everyone usually talks about. I love talking about B vitamins. B vitamins are necessary. All the B vitamins are necessary for so many things in our system. So there's a few I want to point out before I get to what I lovingly call the gateway genes. I always call this Cuban. That's not what it is. It's just how my brain reads it. But CUBN, this is specific to pernicious anemia. So if you have patients that are B12 deficient and you're giving them oral supplementation all the time, but they're not responding well, chances are they have a CUBN variation and they actually need injections. So we usually suggest you need to get either methylcobalamin or hydroxycobalamin shots once a week, twice a month, whatever their timetable is, and then supplement with oral B12 on a daily basis. Excuse me. I have been able to catch more pernicious anemia cases due to this gene variation than anything else. And it's quite an interesting, there's a lot of research behind it. I highly recommend going and doing a deep dive into PubMed for that. But it's quite interesting. These are also your autoimmune patients that are going to be prone to having that. So MTHFR, this specifically is a do you need methylcobalamin gene? It is, you're getting your various B12s from different food sources, mostly animal protein, but are you converting it into methylcobalamin? And do you need to supplement? So most people with MTHFR are going to show variations in that gene, I should say, are going to show that they are deficient in B12. And specifically, we utilize methylmalonic acid for that test, or we do intracellular blood work. I do not ever rely on serum B12 levels. Excuse me. Okay. 3, and yes, they're that important. 3 BCMO1 genes. This is my third favorite, and I have a total hierarchy of my favorites of genes. BCMO1 is a vitamin A conversion. This says you're going to be able to eat a carrot with lots of carotenoids, the inactive form of vitamin A, and turn it into retinoids, the active form of vitamin A. Depending on which gene variation you have, how many of them, if you have all 3 especially, can determine how severe your vitamin A deficiency becomes. And the reason I like this is because, and the reason I use all 3 of them, there are quite a few, but 3 that have really solid backing for research. I almost always see vitamin A as a deficiency that's overlooked for many practitioners. I think it's underutilized as a supplement. I think most people aren't looking for it because it's not a cheap blood test. I will give you that. And it is highly linked to things like thyroid disorders, growth problems in kiddos. So kids that need to have growth hormones, I would check their vitamin A levels. It's linked to immunocompromise. So if you're getting COVID every other day, maybe you need some vitamin A. It's an autoimmune oriented gene. And the way I see it, if you are dealing with pediatric patients at all, if you have pandas or autism, chances are they have a vitamin A deficiency, at least in my personal experience. And this is definitely a compounded gene. So if you've got 1 variant copy, if you've got 2, it's worse. If you've got 3, it's even worse. So the more BCMO1 variations you have, the worse your deficiency usually is, and the more vitamin A you might have to take, or the longer you may have to take it. SUT2, I think, is a highly misunderstood gene. The research is a little contradictory, but on the surface, FUT2 just says you're either going to appear low or high on a serum B12 test. For me, that just says don't do a serum B12 test, do methylmalonic acid or an intracellular test instead. But where this becomes fun is that FUT2 is also related to whether or not you secrete oligosaccharides in your mucous membrane. So oligosaccharides are a specific type of carbohydrate that can help create a healthy mucous membrane in your digestive tract, your nasal tract, everywhere that you have a mucosal membrane. And if you're a non-secretor, you tend to have, meaning you're not secreting those sugars in your mucosal membrane, you tend to have more gut dysbiosis. You tend to have quote unquote leaky gut syndrome or infections chronically. And if you know that about a person, these are your people who can't tolerate fibers, or they may have histamine issues, or they may think that they can't digest oxalates. They have massive issues with digesting different things. Chances are they just don't have a healthy mucosal membrane. And if you actively work to fix the mucosal membrane with these people, the non-secretors, then all your other work becomes much easier. But I will say that most of my non-secretors are the people who have been to practitioner after practitioner after practitioner. Everyone's trying to put them on a cookie cutter protocol, but they just don't work the same gastrointestinally. So if you're really trying to get to the root cause and be a gut doctor, so to speak, you need to know whether they secrete oligosaccharides in their mucous membrane or not. And FUT2 will tell you that. Here is maybe my least favorite gene of all. The one I lovingly call the gateway gene because I think it's been blown out of proportion over the years is MTHFR. MTHFR, both 1298 and 677, the whole purpose of this gene is to tell us whether we can have dietary folate and turn it into methylfolate or usable folate. If they've got one heterozygous copy of 1298, no biggie. If they've got a homozygous variation of 1298, you're 40% less efficient at converting your dietary folate into methylfolate. 677, however, if you're heterozygous, 40%. If you are homozygous, up to 75% less efficient at converting both folate and B2 from the food base to the cellular base. Now, why does that matter? It's a big deal because folate, B2, and B6, and B12, I'll give it that, are needed for so many processes in the body. Folate alone is needed for over 200 biochemical processes, specifically through what we call the methylation pathway. That's a whole other topic, which we can do one day. And because these genes, the variations of these genes are so prevalent, that means so many people are potentially folate deficient. And if you don't have folate, you might have problems. Is it that you have an MTHFR variation, you're automatically linking that to everything that's wrong with you? I think that's where we've gone wrong in genetic testing. I think it's the folate deficiency that needs to be blamed, not the gene, because so many people have this variation. It's not the gene alone that's the problem. So never hang my 2 cents, take it for what it's worth. Never hang your hat on MTHFR alone. Look at how it is related to everything else. All right. I know we're getting short on time, so I'm going to run through some of these minerals to get to some of the stuff I think might be even a little bit more important. So SLC 30A8, HFE, SUOX, and BDNF. These are 4 of the most mineral-oriented genes I see. And when I say minerals, it really is related to all of them. HFE is the only one here related to iron alone. The other 3 are related to many minerals, but I generally focus on magnesium deficiencies and zinc deficiencies with this, especially BDNF and HFE. We specifically focus on the one that causes hereditary hemochromatosis. So this is going to tell us whether your patient can take iron supplements or not. So that's helpful. And if you have someone who is seeing signs of hereditary hemochromatosis, you can tell them to go give blood as part of their treatment program. It's very useful. SUOX is also helpful because it tells us how well their sulfur detoxification processes are going. So are they utilizing sulfur enough? Is it turning into ammonia? Specifically with this, if I see a SUOX related gene, I give them molybdenum so that they can actually process that sulfur a lot better. And like I said, the other 2, magnesium and zinc, are the big ones. BDNF, I think, is important because it's brain-derived neurotropic factor. So if you've got TBIs, if you've got mental health issues, if you've got sleep issues, anything neurotransmitter-oriented, this is a big magnesium push, okay? So if you've got a BDNF variation, you're going to want to give them magnesium glycinate or malate along with any other treatment protocols you might be doing neurologically. Inflammation. A lot of these genes could be used for inflammatory pathways. But what I typically see most often are these 4 on the screen: MYRF, FADS2 and 1, and PEMT, specifically as they relate to omega-3 fatty acids and choline. PEMT is a big choline deficiency gene. If you have a variation of this particular gene, you are most likely going to be deficient in choline. And because choline works with folate and magnesium and methylation pathways and all those fun brain oriented things, we see a lot of liver issues and brain issues when choline is deficient. So I do pay close attention to that one. The others are your generalized omega-3 fatty acids. So if you're going to give fish oil in your practice or encourage them to eat seafood, these are some great genes that respond beautifully to fish oil supplementation. But this one, I do want to focus on PEMT because that choline, you need it for pregnancy, you need it for avoiding dementia or treating dementia, depending on your type of practice. I see a lot in non-alcoholic fatty liver disease patients. Choline can be a game changer for a lot of people. And if PEMT is present in a variation form, then choline has got to be one of your first things you consider. APOE. This is actually on our test. We do not yet have a page for it that's coming in the next month. But this is a big deal for lipid transportation and inflammation. And if you do anything with Alzheimer's or dementia, APOE is usually top of your mind. So we test for the variation copies. I'm not gonna go into it in a huge amount today because we're running out of time. But if APOE is something that you want to see, we do test for it. Some patients, however, do not want to know the answer. So if Alzheimer's runs in their family, you really need to check to see if your client wants to find out if they have the quote unquote Alzheimer's gene or not. There's a lot of dietary changes that can be done to minimize the effects of specific APOE types, but it's a touchy subject, let's say. And again, I can spend a whole hour on that. If you have specific questions related to APOE, I'm happy to talk. Now, detoxification, everyone wants to talk about. There's two main ones that we consider, GPX1 and Pawn 1. GPX1 is, do you make enough glutathione? Glutathione is your master antioxidant. It's really important in detox pathways. If you have a variation of this gene, you're going to generally be deficient in it. I almost always see deficiency here. But sometimes you're also sensitive to medications that reduce glutathione. So if you're already prone to glutathione deficiency, if you need dental work with nitrous, if you need Tylenol or anything else that deals with, anesthesia, excuse me, those naturally deplete your glutathione levels. So if you already have deficiency and then you take those drugs, you're really going to be having difficulty metabolizing drugs out of your system. I usually recommend keeping glutathione on hand as a supplement form so that you can better handle that metabolism. Pawn 1 is environmental pesticide oriented sensitivity. Every single human is sensitive to pesticides. It just, depending on your allele type, determines how you react. So if you're a CC allele type with a Pawn 1 variation, kiddos specifically, you're going to see a lot more autism and sensory processing issues. Adults with a TT allele type are going to see more cardiovascular issues, a lot of stroke type symptoms, varicose veins, that kind of stuff. But we can't live in a bubble, but everyone is sensitive to pesticides on some level. Now, I know I'm going really fast because we're running out of time, but I have 4 more genes to talk about. And this is my absolute favorite because I'm a big neurotransmitter oriented person, a neurology person, is how you metabolize your neurotransmitters. And then I'll get to your questions. H and MT. This is your histamine transfer oriented gene. So your cellular histamine levels throughout your body. If you have issues with histamines and you're eating a high histamine diet, or you live in a very allergy oriented climate, you might have seasonal allergies. You might have asthma. You might have migraines. You might have miscarriages. There's a variety of things that go along with histamine. I see this a lot in my histamine intolerance clientele. So if you have mast cell activation disorder or you're questioning that, looking at this gene can help determine, do you need to go on a low histamine diet? Do you need to take things like quercetin or nettles every day? It's very important. But it's also neurotransmitters. So your anxiety people, it's not just that you're allergic to things. It's Are you having high histamines creating an anxiety or panic attack? You could really use this in your mental health practices. COMT is the other gene that so many people use, and I love it. It is basically how you metabolize dopamine. Now, it does play on every single neurotransmitter, but dopamine is typically the one that we look at the most with COMT. And the fun thing about this, and it goes for the MAOs as well, is the wild type versions are just as bad as the homozygous versions. It just does something different. So, the most commonly found versions of these genes may process metabolize the neurotransmitters slower or faster versus the homozygous variation. The heterozygous ones, I think, actually have it the best because they tend to be balanced. But COMT people, they're either going to metabolize dopamine very slowly and get a buildup of it. And then you end up with things like anxiety or insomnia, restless leg syndrome, anything that I would call like a fight or flight type symptom. Or you're going to have the people that burn through it fast and they're going to have issues with addiction. They're going to constantly be looking for that next dopamine hit. They might have depression. You see a lot of mental health issues on either side of the coin. And the same goes for MAO. Now, MAOA is my absolute favorite gene. Okay, so you now know my top 3 favorite genes. MAOA I see most often because most people do not metabolize serotonin as quickly as they ought to. So they get the fight or flight symptoms as well. And these are your people that have insomnia, they have excessive sweating, they have anxiety, they have ADHD. They are probably the bulk of my clientele. And with that, there are specific things we can do. They actually don't tolerate fermented foods very well. And I can get into that again later. But this is something you need to watch out for because so many of us are trying to fix the gut by saying, oh, have your kimchi and your kombucha, your fermented foods, when in reality, 60% of our population can't actually tolerate fermented foods based on neurotransmitter production.
Welcome to Rupa Health, the best place to order, manage, and track results from over 30 different lab companies in one single place for free. It's going to take you under 2 minutes to sign up, and you can order any functional medicine lab for your client in under 30 seconds. Let me show you how it's done. So here's our beautiful interface. I'm typing in the name of my client, selecting the lab that I want to order for them, and hitting send. From there, Rupa and their amazing team handle the rest. They email the client, collect payment, and even offer an interest-free 3-month payment plan. We've also built the world's largest library of information about chronic health conditions, the lab tests that can help you find the root cause, and the evidence-based interventions that you can use to help people heal from them. It's called the Rupa Health Magazine. There, we have in-depth articles about almost any health condition you can imagine. And we give you step-by-step protocols that other clinicians have used to help their clients heal and that are verified by evidence-based sources. You should totally check it out, and it'll transform your practice. And we can't wait to see you. So make sure you sign up today at rupahealth.com.